next to Dr. Abdu Adem Yusuf. He's going to talk about the fellowship again in hematology oncology and what the training, service, and research looks like.
Thank you. So I think it's very difficult to be last presenter for such long day. So to make my presentation exciting, I think we need to have some kind of refreshments, a refreshment exercise. So ask you, all of you to stand up. Okay, በአማርኛ እናድርገው። ወደ ላይ ወደ ታች የተሳሳተ ይቀጣል። ወደፊት አንድ እጅ ወደ ላይ ቀኝ ግራ ይመለስ። ከዛ እንደፊት ይላል። Okay, now you can sit. Okay, thank you very much having me here. As I told you, it's very difficult to be the last presenter, but at the same time, it is an opportunity for me because most of the things that I'm going to talk about will give sense after hearing all the presentations. So I'll be presenting on the hematology, adult hematology oncology curriculum, which is at this last stage of development at St. Paul Hospital Millennium Medical College. And I'm very honorable to be here at this stage. So I'll be focusing on these 4 points. I will give you the rationale why we need this curriculum in Ethiopia. And I will also update you the current status where we are in the curriculum development and what makes it very, very peculiar, our curriculum, especially in the light of the accreditation that we have been talking the whole day and as was presented by the other presenters. So I will tell you a little bit about our curriculum and the areas that we want from collaborators like P2P and other collaborations to realize this curriculum. So as a rationale, as mentioned earlier, in Ethiopia, the healthcare force, especially in cancer care, is very, very limited. As you all remember, the oncology residency program was started almost like in 2013, and that was the first batch. So at that time, there were only 3 doctors, oncologists for the whole country. So you can imagine how difficult, almost it was non-existent. So they started the residency program, the oncology, clinical oncology residency program in the Grand Hospital. So that was doing great a lot. And, currently there are almost like 42 clinical oncologists like me practicing all over the country. So that is a great step in the health workforce. But these oncologists and the gynae oncologists and the other hematologists, almost all the healthcare professionals that are serving the whole population, they are concentrated in the major cities in Addis and around Addis. So patients, they have to travel all the corners of the country, to reach to these countries. And the clinical oncology, the existing clinical oncology program that is running in the Grand Hospital, played a lot of role in cancer care, but there is still inequity. Because most of our patients, especially, for example, in our hospital, St. Paul Hospital, more than 60% of our patients are coming from rural areas and from other regions. So there is an access problem, and we are not reaching those patients coming from all corners of the country. So we need people, we need HR with a trained workforce, and at the same time, we have to increase the quality of care. So that is the whole rationale, or that is the whole idea of starting this fellowship program. So the hemato-oncology fellowship, as I told you, there is from the Ministry of Health as well, there is a huge investment running in expansion of cancer care services. So in 2015, the cancer control program policy was designed. And based on that, there was a plan to open radiotherapy, 6 radiotherapy centers in addition to the Columbus Hospital. So it was in 2016. Now we are in 2014. So you can see that over the past 7 years, only 2 centers started giving radiotherapy. I know radiotherapy is a huge investment, not only for Ethiopia, but also for the developed countries. So probably the plan was very, very optimistic for me. So, when we see the huge investment that is required for radiotherapy services, uh, we understand that the pace of the pace of generating the trained workforce and expansion the facility will not go together. So there is a huge possibility that the radiotherapy service will be limited in major cities. Now, Awasa, Jimma, and Gondar, they are installing the radiotherapy centers. So probably in the coming years, we'll have 2 or 3 additional radiotherapy centers. But after that, it is impossible even for the country to expand the radiotherapy center. So, the program that I have been also passing through is, as a clinical oncologist, majority of our curriculum is focusing on radiotherapy. So I was trained for 5 years, and almost you can say that like 60, 70% of my time was in radiotherapy. But since my graduation in 2017, I'm not practicing radiotherapy because the facility cannot uh, realize the radiotherapy center because it is intensively resource investment requirement. So, the who give the service that I am now providing, I don't have to waste like 5 or 4 years. We can't train other people that can treat patients without radiotherapy. At least they can treat cancer patients and they can send those patients requiring radiotherapy to these centers. Because as I told you, even the prospect in the future, we don't have radiotherapy centers here in the Z. We'll have a very limited number of radiotherapy centers. So even the Minister of Health, they have to consider that, clinical oncology program may not be needed. We have to separate as medical and radiotherapy. Because if you train a person who is not going to work with the training, that is a loss. That's a loss. So that is what we feel. And that is why I'm in the hematology oncology fellowship program. And that is one of the rationale. So what are you going to do with this hematology oncology fellowship? So this is most commonly asked question in different meetings we have. So we are going to train internists, hematologists, and clinical oncologists because these are all the professionals that we have in our country providing almost cancer care, like clinical oncologists and hematologists, but still a lot of pool is there in the internal medicine department. So we are going to accept these candidates. So we are expecting at the end of this fellowship, as a scope, they are going to treat both benign and malignant hematologic disorders and solid malignancies without radiotherapy. And this is in line with the Minister of Health policy. If you read the subspecialty and specialty roadmap of the Minister of Health, they are, clearly stated that they want to expand specialty and subspecialty service. And if you see the 3-tier levels of the Ethiopian health system, it is in the general hospital, in the primary hospital, that these professionals, they can work there. By now, as a clinical oncologist, I can't go to the general hospital because I need radiotherapy. But when I have to go to the general hospital, there is no radiotherapy. So that is a reality. And that is why we want to tackle with this curriculum. So for me, this hematology oncology fellowship is a stick that is killing more than one bird with one stone. So far, we developed the implementation strategy and the need assessment was done. And as Dr. Mariama described earlier, we followed all the steps that is required by the college. So the need assessment was presented on the workshop. Curriculum was completed with the curriculum developing committee, and then we also held the internal curriculum review on that date. And last month we had, in the presence of Minister of Health and society and different stakeholders, as you can see, we concluded our external validation. So only one step is in front of us. So we have to present this to our for Senate. Then after we can receive our fellows based on the curriculum. And also, in addition to that, as Dr. Mara might mentioned, now the capacity of St. Paul is building up, but we need still collaboration because we need our fellows to be capable of, knowing what is going on in the world. So Dr. Kabeda was telling us, what is the updates in the personalized medicine in oncology. So they have to see, and for that we signed a MOU with people to people, at least for the abroad attachment of our fellows. And we started a very fruitful communication with College of Health Medical College, which is in India. So that is a very handy and a very good institution for our fellows. So we started our communication, and probably in the coming few weeks, then we will be finalized. So this is a preparation for the hematology oncology fellows that we are doing. And coming to the peculiarities, the curriculum development, it is very different from other fellowship programs that we have. As you have heard from our Dr. Maremoit, our Dean of Medical School Dean, most of the curriculums they developed by the trainers themselves. But here in our hemato-oncology fellowship, we used from people, different professionals, including myself, for the content-wise, the hematologist, and the people, experts from the health science education development. So it was developed in a workshop manner, and it has a very good input from different stakeholders. So I can proudly say that this curriculum development process itself is a unique for our fellowship program. And the other one is as I told you, the main rationale for this fellowship program is the access to improve the access of cancer care to the periphery. So we designed the recruitment criteria to meet that goal. So we are not going to accept professional hematologists, internists, or oncologists from Addis or from those areas that have, in quotation, like adequate oncology care. So we purposely put that criteria so that we are going to recruit people or fellows from remote areas so that they can be trained and they can go there and they can establish the hemato-oncology service, at least by the status of the setting they have. So that if they have a patient that needs radiotherapy or very advanced care, they can refer to the centers. So this is very written in bold in our curriculum. And the other one is, as currently I'm also working as a quality director, and as a physician, when you are graduated from a medical school in our country, what you know is how to treat a patient, not your setup. You don't know your setup. You don't know your setup. I understand the process that to buy a single pen and to buy a car is very similar in our bureaucracy, because I am working right now as a quality director. I don't understand these dynamics during my residency or my undergraduate program. So for that, we are going to have, for our fellows, they have to know their facility. They have to know the system. They have to see how to run the system. And they have to understand how to establish a system, because we want them to be a leader. We want them to be, system establisher, because they are going to work in the periphery and they are going to start from the scratch and they have to know. So we dedicated induction, orientation, and the facility to almost for 2 weeks at least. And during the whole stay of the remaining of their whole stay, they will understand how they can establish when they go back home. So this is other peculiarity. And the other one is we included different teaching modalities, teaching learning modalities. For example, as you might heard, currently where it's an adult learning. So usually what you use is a dedicated, a didactic lecturing type. But adults, I know that most of you may not be attending me right actively because you are an adult. I know the attention span is very, very short. So you have to give, you don't have to learn the adult with the way that we are using traditionally. So there are very modern implementation or teaching modalities like problem-based learning. You just give them the adult the problem and they come up with the learning. So it is called problem-based learning. And if I know you might be heard that in Amsterdam, in Netherlands, there is one medical school whose teaching modality is completely problem-based learning. Because if you learn through the problem, you don't forget it. Otherwise, through lecture, you forget it when you go out. So we include such kind of teaching modalities, and we give a very emphasis in the multidisciplinarity. So we do have different multidisciplinary modalities in our college. So we give a very due attention to this teaching modality. So we want to use this, the competency framework, but in most of the fellowship programs, if you go in detail in our country, for example, they put like the as a leader, but they don't assess the leadership, and there is no way that a fellowship program that contains how to deliver a leadership program, how to foster a leadership program, a leadership for the fellows, but they write it in the fellowship program. So as I told you, the curriculum development process by itself is unique because we want to include all the modalities to foster this competency for our fellows. So most of our fellowship programs, if you really see, they focus on the first one, medical experts and the scholar. So our most of the fellows and the doctors are medical scholars and fellows. So we want to change this as well. And the other one is, currently, as you told in the morning as well, today now is the era of quality and accreditation. And you have to understand the system that you are working. So most of the people, even the physicians, we don't understand how the system is running, and we don't care about the quality. Now, there was an exhibition held on in our hospital right now about quality of healthcare. So this is the motto globally as well. So our fellows will have a basic quality improvement project training. So they are expected to graduate at least one quality improvement project. Through that process, they will learn how to identify problem, how to sort out, and how to improve it. How to improve it. And they will be certified because we do have a national manual, and we do have an accredited CPID service for that. And basic leadership, as I told you, most of our fellowship programs, they write a leadership, but they don't know how to deliver it, So for that, we do have both local and international speakers, which will give at least basic leadership skill for our fellows. Because as I told you, our fellows, they are expected to go to the periphery to establish hemato-oncology care. So they need leadership skill. Most of us, we know leadership through our life process, not from school. So we want to tackle that as well. And in the morning, I was very, very happy by doctor's presentation regarding pain management. And, around 60-65% of our patients in Ethiopia, they are treated for palliative intent. So palliative care comes first. So we also included palliative care for our fellows. So it is, for me, it is a comprehensive kind of educations that we are planning to comprehend for our fellows. And I have seen also the Stanford curriculum. Uh, you know, by law in our country, you can't extend the fellowship program more than 2 years. And I know that in Stanford and in European countries, they have like a fellowship program for 3 years. But if you count really what they are doing during the 3 years, like 1 year and 5 months is only for the fellowship program for the education, and 1 year and 7 months is for the research. We can't do this here. We can't do this because of the law. So what we did is we integrated the research program starting from the third month, the early attachment of our fellows. So we integrated the research programs throughout their journey. And I can tell you that if you ask Dr. Mariamite, every fellow in our country, in our college, is expected to do research. But as a graduation criteria, you are not expected to publish or to submit a manuscript. You just defend the manuscript, I mean the research proposal, and it's done. So we are not making them researchers. That's what I'm arguing. We are not making them researchers. Fellows are doing research for the fulfillment of graduation. Even the title says a research proposal then for the fulfillment of that. It's not for the making them researcher. So we integrated the research for the research activity from the initial one, and even the until the external validation, we make publication of one article a must for graduation. But during the comment that we have accepted from societies and so on, and since it is like 2 year program, it may be difficult for the fellows at least to publish. And if we make a very good requirement for that, there may be a lag of graduation. So at least we make it like submission of a manuscript, maybe a graduation criteria. But for this, with this, next time we may have a good experience, so that our fellows are coming professionals, they are capable of doing researches, quality researches, capable of publishing them and sharing their experiences. And at the same time, as I told you, research and quality improvement project, they will be doing this. And different in the morning, I was very happy to hear that the accreditation committee, you see, the problem in our country, in our fellowship, the ongoing fellowship programs, for example, they say lectures and so on and so on, sessions, different sessions. And both the instructor and the students, they don't have the objective of that session. We don't know the exact objective of that session because we are not developing that tool. So in our curriculum, we develop a tool for every session, for the lecture, for the supervisors and for the students as well, so that every session is objectivized and they know what is expected from them. And these templates are included in our curriculum. And I think this is very, very nice. And this is peculiar for our curriculum. And not only that, even for the rotation, they do have a lot of rotation in patient, outpatient, diagnostic, even abroad rotations. We send the fellows abroad and they come what they can learn, and we don't know what is expected exactly from that rotation. So we prepared a kind of objectives so that the fellows, they have to meet this objective during their rotations abroad. And if they have time, they can add based on their inspirations. So this is what we make our fellowship very, very peculiar according as compared to the other fellowship program. So what do we have? What do we have at the resource? That is the next question. So I think Dr. Mariamite also presented most of the capabilities that we have, but in relation to hematology, we have a good HR profile, both in diagnostic and in diagnostics. We have a good capacity in St. Paul. So I am not going to all these details, but in HR, we don't have a problem for me. But we'll be using the P2P through the P2P connection. We'll be using the guests, lecturers, and others. And the infrastructure and the material that we have currently, we do have hematology, oncology, pediatric hemato-oncology, and gynecology fellowship programs running. So we do have this infrastructure currently, but we do have also, we don't have radiotherapy, but we'll have it soon. But for the time being, we can use Tukur Ambassa Specialized Hospital. They agreed to help us on radiotherapy attachment. Jimma is also on board. But for and there are also different diagnostic centers, both in our hospital and in private, that are very, very closely working with us for the fellows attachment. So infrastructure wise, we do have this, and our CPD, accredited CPD directorate is very, very instrumental for us to give the fellows. And we have a very our own journal in the hospital. We have a Millennium Journal of Health. So our fellows, they can publish their work through our journal. So this is an opportunity for our fellows, and this is the resources that we have. And the big resources that we have probably in the coming years is our oncology center, National Oncology Center. So this is, as far as I know, this is the biggest oncology center in Africa, proudly speaking. There is no such a dedicated oncology center in Africa. I have been in South Africa. I have been in Western Africa. I have seen also North Africa. There is no such oncology center, dedicated oncology center, having more than 350 beds, radiotherapy bunkers, 5 bunkers, cyclotron, name it, whatever you name it, the oncology care will be here. And for me, it is not a far-fetched possibility, because if you have a chance to visit our center, the construction is almost 95% finished, and the problem we have is with the investment, operational investment. So this is one of the pipeline projects that is held under the PPP board. So there is a plan, a national plan to undertake it. Is under public-private partnership, and after the feasibility study is already finished and it is submitted to the public-private, the PPP board. And there is also another opportunity coming to our doors. St. Paul is the only hospital in Ethiopia having an enterprise license. So we can have, with now currently, this is an MOU signed by our enterprise, and the construction is also begin for integrated diagnostic center. So we'll have an integrated diagnostic center, which will be practicing in the private side. So that will be run as an enterprise, not like in the public. So that will facilitate to attract, investors. And for me, this is not also a far-fetched possibility. So as per the plan, this diagnostic center will be finished in 1 year, and they will be start functioning in the coming 2 years. So these are the opportunities that we have, and our journey of St. Paul starting from 1947, like 77 years old. You have seen the growth of St. Paul even starting 7 years ago. So our journey tells us that we can still realize this opportunity, seemingly far possibility to the reality. We can bring it home. So what we need for this, what we need as a support, as I told you, our oncology center is coming up, and we have a good resource profile, HR resource profile. So what we need is from our collaborators,